Did you know that dysphagia can occur not only in people with head and neck cancer, but also in people with cancers outside the anatomical swallowing regions? This is an area that is often overlooked in clinical practice and is also an under-researched topic. To shed light on this important issue, we interviewed Professor Ciarán Kenny from Trinity College Dublin. In his PhD research, Ciarán investigated the prevalence, clinical characteristics, and predictors of dysphagia in people with cancers outside the anatomical swallowing regions. Join us as we explore his findings and much more.
Hello, Ciarán, and welcome to Dysphagia Matters. We are so happy to have you with us today.
Thank you for inviting me. I'm very, very happy to be here.
In our last episode, we had Kate Hutchison as our guest. One of the things she explained was why people with head and neck cancer often present with dysphagia. You have worked with people with cancer and dysphagia outside of the head, neck, or upper gastrointestinal tract. So how did you become interested in this topic in the first place?
Well, I suppose, like a lot of researchers, my interest in the topic originated from some things that I was seeing clinically that didn't really make a lot of sense to me. So I was working at the time in two acute hospitals, both of which had oncology teams and saw people with cancer, but neither of which particularly specialized in head and neck cancer. And yet I was getting a lot of referrals for people with dysphagia from those oncology teams and from the palliative care teams as well. And I was always interested as to why it should be the case that someone who might have, for example, prostate cancer or a bone cancer may develop dysphagia. And so my interest started from that original question, I suppose. Why am I getting referrals for these people? And then from there, I suppose I ended up becoming linked in with a wonderful organization called Atlantic Philanthropies, which was an organization that funded a lot of research and was thanks to, I think he was a billionaire, Chuck Feeney, who passed away recently. He had arranged before he passed away to give all his money away to try and make the world a better place. And he very kindly, not him directly, of course, but his organization funded the piece of research that I was interested in. And so then as I started to look up the literature more and more on this topic, I realized that dysphagia in people with cancers that are outside of anatomic swallow regions were historically, or dysphagia was historically neglected in the literature. So in other words, I think that we have, as researchers in swallowing, been really interested in dysphagia and how it manifests in head and neck cancer and in esophageal cancer. But for people who have cancers in other parts of the body, we haven't done a lot of research in the area. And so that's what originally started me on this journey.
And according to your clinical experience and your research, what causes dysphagia in this population? Because, as you said, the anatomic swallow regions are not affected by the cancer.
Well, I suppose the answer to that is that dysphagia is multifactorial. There's no one cause, I would say, to dysphagia in this group of people. There is definitely an element of motor dysfunction, I found through my research, and that can occur in people of any age. What I suspect is the cause of the dysphagia when it comes to motor dysfunction is what's known as cancer cachexia. So we know that sarcopenia is an age-related swallowing problem caused by a lack of skeletal muscle strength or activation. And cancer cachexia is quite similar. It's a loss of muscle mass, but also fat loss as well within people with cancer. What we also know is that in people with cancer, fatigue is one of the most common and burdensome symptoms that they have. What we don't know, I happen to be working as part of my research with someone who is interested in cancer-related fatigue, and what we still don't know really is to what extent the fatigue is caused by the cancer versus the loss of muscle mass or exhaustion or lack of strength because of loss of muscle. Within the research, and I might talk about this later, I did find that there was poor motor performance, which might be one factor involved in why people develop dysphagia. I think the other thing that I found, which is important to mention, is that dysphagia is not just aspiration, right? It's not just penetration and aspiration. And in fact, this group of people often had oral preparatory and oral phase difficulties, which is one of the less common difficulties that we tend to encounter in dysphagia. We usually focus a lot more on what happens at the pharyngeal level. And I suppose related to the oral cavity as well, a lot of the people in this piece of research that I carried out had xerostomia or dry mouth and mucositis as well. Another interesting feature of cancer, which is really frustrating for people with cancer, is that they often experience taste and smell changes. And I wondered whether, as part of the research I carried out, those taste and smell changes might be interfering with swallow initiation, because we know that by way of compensation, sometimes we use enhanced sensory properties to try and promote somebody's swallow to activate. So what we don't know, I guess, is whether people with taste and smell changes have poorer activation of their swallow function. And then I suppose another point that I would make as well is that dysphagia in this group of people, and this was a really significant finding from the research, but not one that actually matched any of the research questions I originally intended to ask. So maybe it's not very clear in what I've published so far, but a lot of the people in the research that I carried out had difficulty discriminating between dysphagia and other symptoms that they had as part of their cancer. So, for example, they felt like they weren't hungry, what's called early satiety, and therefore they wouldn't eat, or they would feel nauseous and not eat. And so when I was asking them about difficulty swallowing, in their minds, they didn't know where a problem swallowing started and where nausea or a lack of interest in eating ended. A lot of the work that I did with the people who participated in this research was to try and discriminate one from the other so that we could talk about a physical difficulty getting food or drink down, which is often how I described it. So I suppose in answer to the question, I think there's probably no one cause of dysphagia in this group of people. I think it's probably a combination of causes.
That's really interesting that you mention the pre-oral stage as well, because sometimes I feel like even researchers or clinicians aren't quite sure if we should include this phase or not. So it's interesting that people are experiencing those difficulties weren't sure either whether this belongs to the swallowing phase or swallowing process itself or not. Because I'm interested, maybe you've found more about this, but whether this actually influences then the swallowing process or not. If someone isn't hungry, does this have an impact on the swallowing process itself or not?
Yeah, I wondered the same thing myself, and I suppose the short and disappointing answer is that I don't know. But when I was approaching these people who were living with cancer, they were saying that even the sight of food or the smell of food was really making them feel quite sick. Whether that has an influence on timings of oral phase or pharyngeal phase or anything else, I don't know. Whether it interferes in any way with swallow activation, I'm not too sure. I suppose I had been talking about taste and smell and promoting or inhibiting initiation of swallow. Maybe that's also a factor. But yeah, the pre-oral anticipatory phase, of course, we talk in other populations of people, like people with dementia, that perhaps they need orientation to eating and drinking tasks, and that may help support them. But in fact, being oriented to eating and drinking was something that often made people with cancer feel quite disgusted. They didn't want to see food or smell food. Whether that has an influence on cortical activation or not, I don't know. I suspect it probably could.
Yeah. So in one of your studies published in 2019, you looked at the prevalence and predictors of dysphagia in people with cancer outside the anatomical swallowing regions. So how common is dysphagia and what are the predictors of developing dysphagia in this patient cohort?
Yeah, so the study recruited 385 people with cancer. They all had solid tumors outside of anatomic swallow regions. Overall, the prevalence was 19% amongst the entire cohort of people. I recruited people from a private hospital, a public hospital, and also a hospice service, which provided care to people who both had private health insurance and who were under the public healthcare service. And that becomes important a little bit later on. The prevalence of dysphagia rose to 30% for people under palliative care and 32% of those in hospice care. And of course, you can be in palliative care and in hospital, which is why those two figures are different. The predictors of dysphagia, I suppose you could summarize that by saying that things that were markers of functional impairment in the person's life were significant predictors of dysphagia. So there's a tool called the ECOG-PS, the Eastern Cooperative Oncology Group Performance Status Scale, which is a very easy scale that just describes how well someone is able to engage with their activities of daily living. And worst scores on that indicated dysphagia, as did having multiple comorbidities, or if you were someone who had cancer cachexia, or as I said, if you were someone who was under palliative care rather than receiving curative intent for your cancer, then you are more likely to have dysphagia as well. So things that indicate decline in function were predictors of dysphagia. And that matches up with previous research that had been conducted in the area too. When I did begin the research, the only research that really existed in the area was from people who were specialists in cancer rather than people who were specialists in swallowing. And they had noted that dysphagia started to appear within the last week of life. And I suppose one of my original questions was, does it actually appear earlier than that? And maybe are we just not picking it up well enough? And do you need a swallow expert to come along and figure that out? I suppose I looked as well at what are called cancer symptom clusters. So a lot of research has been carried out by oncologists on this concept of symptom clusters, which is when you go through a symptom checklist with patients and you ask them to say, yes, I have this, or no, I don't have that. And there are very long lists of symptoms that people with cancer experience. And some very clever researchers have grouped all of those together to see which symptoms commonly co-occur with one another. And it had previously been identified that dysphagia tends to co-occur with cough and dysphonia and other symptoms as well. And really, I was just verifying whether that was the case on the basis of a more careful assessment than simply asking someone, do you have difficulty swallowing, which is what the previous research had done. And I found that, yes, people who had a chronic cough, dysphonia, early satiety, which is to say feeling full very quickly, were very likely to have dysphagia as well. And I suppose one of the interesting things about cancer symptom clusters is that the concept itself is based on the principle that perhaps if all of these symptoms are appearing, maybe there's a common underlying cause for all of those to appear. And if you think about it, I think that the vagus nerve, for example, influences a lot of those symptoms that I just described. So perhaps the vagus is somehow responsible for dysphagia as well as some of these other conditions as well. I suppose the other thing that I should mention is that an unusual predictive factor that I didn't expect from the outset was that dysphagia was much more likely to happen in people who are under publicly funded healthcare services rather than people who had private health insurance. And I guess I didn't investigate that from the beginning very carefully, other than to document whether they were a private or a public patient. So I couldn't explore it in a lot of detail, but looking at the literature, it does seem to be the case that people who are not able to afford private healthcare, who are maybe from a poorer socioeconomic background, they don't tend to engage as quickly in health promotion activities and in terms of taking care of themselves. And they may not seek medical help or advice as early as people who have access, quick and easy access to health providers, right? So perhaps that's one of the reasons why being under the public healthcare service was predictive of having dysphagia.
That's, wow, yeah. Interesting, and I don't know how to say that, maybe frustrating as well. But just to maybe put it in context, because this is so different in so many countries, do you know approximately by any chance how many people have private health insurance compared to public health insurance in Ireland?
That's a good question. I don't know the answer to that. I mean, in Ireland, there's both an incentive to buy private health insurance because you get a tax deduction for it, and there's also a penalty if you take it out too late in life as well. So we have this two-tiered healthcare service in Ireland where our public services are very good, but also overwhelmed. Our private healthcare services are also very good and are also very busy. But I think, for example, if you were hoping to see a doctor in Ireland for something, unless it's extremely urgent, you could be waiting a very long time, whereas you will typically receive an appointment within a few weeks privately. But I don't know the answer to the question of how many people have private versus public health insurance.
I was just thinking that might be interesting to get a sense for what this might mean in other countries. So we've done a quick online search to give you a brief insight into the distribution of private versus public health insurance in Ireland. And according to Statista.com, in 2023, about 47% of people in Ireland had private health insurance. So it's about 50-50. Bear in mind that this can be very different from country to country. One other question, considering differences in the public and private hospitals, do you know if there are more SLTs, for example, in the private hospitals than in the public hospitals? And would this have an impact on the care they receive?
That's a good question. I don't know.
Based on the hospitals that you've been working in or collecting the data.
That's what I was going to say, because I can only speak to the ones that I recruited data from. But The public hospital probably had more speech and language therapists. It had a higher capacity in terms of number of patients, but more speech and language therapists per patient, I would say, but I'm not 100% sure about that.
Okay. In another study that you published in 2022, you investigated the clinical characteristics of dysphagia in people with solid tumors outside the head, neck, or upper gastrointestinal tract. Could you maybe first explain what solid tumors are?
Yeah, sure. So solid tumors are when cancer cells grow as a mass inside tissues or organs. And that's by contrast to non-solid tumors, which are systemic and they exist within the circulatory system. So within the blood or the lymphatic system, usually. Solid tumors are more common in adults, while the age profile of people with non-solid tumors tends to be a little bit younger. And we're probably all familiar, of course, with children who may develop leukemia, for example, which is a common form of non-solid tumor. And the implications for solid versus non-solid in terms of someone doing research or clinical work is just that the treatments for both, as well as the age profiles being different, the treatments for both types of cancers are also different. With a solid tumor, you can obviously choose options like surgery and radiotherapy, which can directly target a site, which is not always possible for non-solid tumors.
And what are the clinical characteristics of dysphagia in people with solid tumors? How do they present?
The dysphagic characteristics were, from the research that I did, I suppose, a little bit challenging to profile for a few different reasons. Firstly, the group of people I examined with dysphagia were a subset, right, of the entire cohort. So I screened 385 people for dysphagia, and of those, 73 had dysphagia. So the findings from the research were on the basis of the 73 people who had dysphagia. Since this was novel research, it hadn't ever been carried out in this area before. I also made the decision to just use clinical bedside swallow evaluation rather than something like video fluoroscopy or FEES because they're expensive, they're time consuming, they're burdensome for patients. And I didn't know whether they would add a lot of information to what I wanted to find out. They may have, but it was better in my mind to do something less invasive for patients and more practical and functional as well, bearing in mind I was evaluating people who are under end of life care as well. So it made sense at this point in time not to use instrumental evaluation. When it came to doing the clinical bedside swallow evaluation, of course, I carried out a cranial nerve exam. I performed an oral health assessment as well using the oral health assessment tool by Chalmers et al. And when it came to using a clinical bedside swallow evaluation, I needed to choose what protocol I was going to use. And there are very few formalized clinical bedside swallow evaluation protocols. I had a look to see which one I would prefer to use, and I ultimately ended up using the Mann Assessment of Swallowing Ability, the MASA. The reason why I chose that is that although it was validated with stroke patients, it was at least a validated tool. Your listeners may know that there's another version of the MASA called the MASA C designed for people with cancer, but the MASA C has questions that are very particular to head and neck cancer. And head and neck cancer is quite different to cancers outside of anatomic swallow regions. So I was left in a difficult situation where I could choose the MASA, which was kind of designed for people with stroke, or the MASA C, which was designed for people with head and neck cancer. And on balance, I reviewed the literature. I carried out a systematic review on tools that could be used with people who have cancers outside anatomic swallow regions. The MASA had been used with general dysphagia populations. So on balance, I decided to go with the MASA. So that becomes important later on. I'll explain about the limitations of that in a moment, but I went on and I evaluated people for dysphagia at bedside, as I mentioned, with cranial nerve exam, oral health assessment tool, and MASA. They were rated using the functional oral intake scale as well. Of those with dysphagia, 59% had cranial nerve problems, and these were primarily motor deficits. But as I mentioned earlier, a lot of people had cancer cachexia, and a lot of the cohort, of course, as well, were an older cohort. So how much of that was cachexia versus sarcopenia, I don't know. A lot of people had dry mouth. 66% of people had dry mouth. 38% had lingual coating. 25% had mucositis. So there were a lot of oral difficulties as well in this group of people, and that may have contributed towards some of the dysphagia that they were experiencing. A little over a third, 34% of people were using dentures. Denture use may be associated with some difficulties eating, but it was not the case that the people in this study had loose-fitting dentures, and that was the cause of their dysphagia. It wasn't that they simply lacked dentition and couldn't chew their foods. They did report that they were feeling very fatigued, chewing foods over and over and over again before they could swallow them. And in fact, a lot of people had to take food out of their mouth because they couldn't initiate a swallow. The MASA scores were quite high, and on the MASA, a high score indicates a fairly intact swallow function. So in a way, disappointingly, as a researcher, the MASA scores were high because people were actually reporting a lot of difficulties eating, drinking, and swallowing. But I think that's because the MASA wasn't designed or is not designed to capture the particular type of swallowing difficulties that these people were having. It's quite focused on penetration and aspiration. In fact, there were not a lot of pharyngeal stage difficulties that I could determine from this group of people, and it was predominantly anticipatory, oral preparatory, and oral phase difficulties that they had. So you might expect higher scores on the MAN assessment of swallowing ability, but one nice thing about the MASA is that it does allow you to interpret the risk of dysphagia. And there was a high risk of dysphagia in this group of people with cancer. I did find as well that 32% of people had a cough response to the bolus when they were eating and drinking, but actually it was really on food rather than fluids. So they were having a lot of difficulty with foods, and predominantly with dry, crumbly foods that were difficult for them to masticate and swallow. And then I suppose in terms of dysphagia characteristics, the last point I'd probably make is that diet modification was really what characterized this group of people. So a lot of them had already modified their diet to some extent because they were having difficulties swallowing. And remember, I mean physically getting things down rather than modifying their diet because they didn't feel like eating something. 53% were still on an IDSI-7 diet, which is good, but that left a balance who were on a modified diet, predominantly IDSI-5 and IDSI-6 foods. There was only one person amongst those 73 who needed fluid modification to IDSI-2. All the rest managed fluids well. But having described all of that, people who work with those who have dysphagia will prioritize the use of compensatory strategies over the use of diet modification in order to facilitate our clients, our patients, to have meals that are as enjoyable as possible and to live life to the best possible extent. So I did examine the compensatory strategies that people were using and also ones that would be recommended for them on the basis of the difficulties that they were having. 18% of those with dysphagia were people who would benefit from or were already using compensatory strategies for food, and 33% of them required compensation for fluids. I suppose the most common compensations, what we often think of compensatory strategies as like postural adjustments and things like that, right? But the most common compensation was for the patients themselves to moisten dry foods or completely avoid things that were causing them problems. Meats were a big problem, for example, in terms of not being able to chew well enough and, as I said earlier, not being able to initiate a swallow. So they would avoid things that were problematic.
Were people self-modifying, so just based on their experience, and or were SLTs recommending those modifications?
Both. A lot of people were already self-modifying their diets before I came to evaluate them as part of this research, but I also trialed things with them following the evaluation. So if they were coughing on fluids, for example, I would try a chin tuck with them. In fact, fluid volume control chin tuck head turn were the reason why a lot of them did not need to modify their fluids and could remain on IDSI-0 fluids. So that one person on IDSI-2 fluids was because no compensatory postural strategies were effective. The people who had difficulties with food were typically already self-modifying their diets in terms of eating food that had more moisture because they found dry things very difficult. I frequently found myself recommending that they alternate foods and drinks. So during the clinical bedside swallow evaluation, I was using biscuits, for example, or cookies for some of your audience, and they would find those challenging. So we would try alternating fluids and foods or moistening them with some tea or something, and they found that quite useful. So the strategies that I described and the need for strategies was both derived from what the participants themselves were already doing and also what we tried live during the clinical bedside swallow evaluation.
In the study that you just told us about, you also wrote, and I'm citing you here, interestingly, xerostomia did not statistically contribute to swallow difficulties, despite occurring in 2/3. That must have come as a surprise, I guess.
Yeah, especially considering what I've what I've just explained in detail about
Yeah.
the existence of dry mouth. So xerostomia or dry mouth was highly prevalent in this group of people. I think I might have mentioned 66% earlier. That figure was derived from the oral health assessment tool checklist, which is where you examine someone's oral cavity and you note the features within their oral cavity. Now, I did also capture their own reports of how their dysphagia was manifesting, what it looked like for them, and data hasn't been published yet. In terms of xerostomia, it was not significantly predictive of poor scores on MASA, and that could be due to the limitations of MASA that I discussed earlier, but it equally didn't predict poor scores on functional oral intake scale, which I would have expected it to do. Thinking about some of the reasons why that might be the case, we know that xerostomia is a subjective sensation. So that is the subjective feeling of having a dry mouth. That does not necessarily mean that you have hyposalivation, which is an objective reduction in saliva production. And yet, at the same time, I was inspecting their oral cavities and seeing that their oral cavities appeared dry. Their tongues were dry and cracked and fissured, for example. So that brings us back to, well, why, if there did seem to be an objectively dry mouth, although saliva production was not measured, why was it not related to swallow dysfunction? I don't know. Maybe the threshold for dryness interfering with swallow function wasn't reached by some of the participants. Maybe it was dry, but not that dry that it was causing problems. Or perhaps it's a matter of statistics, and maybe the effect size was just not large enough. With a group of 73 people, where a lot of them were on an IDSI-5 or IDSI-6 diet, and I was comparing that to an IDSI-7 diet, that's not a very big difference in diet modification. So perhaps it's a statistical point rather than a clinical point. I think we would need to research that in more detail to discover to what extent dryness in the oral cavity influences swallow function in this group of people, and indeed in other dysphagia cohorts as well.
Yeah, thank you. That's really interesting. And I like that you point out that it might be a statistical rather than a clinical issue. So it might still be really important to assess it in clinical practice because it might have an influence and we might see that it affects swallowing, but maybe with this data or maybe due to the MASA or just the methods, we might need to alter them to see really an effect in statistics here as well.
Yeah, and I think just on that point as well, I mentioned that there is as yet unpublished data that was taking participants' own views on their swallow dysfunction, and they very frequently mentioned dry mouth as being a problem for eating, drinking, and swallowing. That's why I found it very unusual that it wasn't related to swallow dysfunction on functional oral intake scale.
Yeah. This year, you published a short report on oxaliplatin-related dysphagia. Could you maybe briefly summarize the effects of cancer drugs on the swallowing system?
Yeah, when we think about people with cancer, there are several different treatments. So we have surgery and radiotherapy, which are obviously not drugs and tend to produce more localized effects, although there are some systemic effects from radiotherapy. And then we have drug therapies. Hormonal therapies are used in things like prostate cancer, and they tend not to have a very big effect on swallow function that we know of, at least. And then targeted therapies are the modern form of cancer treatment that have only really come out in the last few decades. The most common form of which is immunotherapy, which trains the body to try and attack cancer cells. And so far, it seems to be the case that immunotherapy also doesn't cause any major swallowing problems. At least I haven't seen anything in the literature about it, and my research didn't find that either. So that leaves chemotherapy, and we do know that chemotherapy causes some difficulties with swallowing. We know that chemotherapy works as a very blunt tool by targeting cells that divide rapidly, and as such, it causes systemic effects within the body. And one of the ways it most commonly manifests, as far as swallow experts are concerned, is in terms of mucositis developing inside the mouth or the pharynx, where a person with cancer who's receiving a chemotherapy treatment may experience burning sensation and dry mouth, and potentially dry mouth then leads to the presence of a candida infection as well, which brings its own problems. So chemotherapy in general causes GI upset too. And we talked already about how people with cancer may not be able to discriminate between dysphagia and GI problems. But the research you just mentioned that I published about oxaliplatin-related dysphagia was slightly different. So oxaliplatin as a chemotherapy agent is used for certain kinds of cancer. It's often used for bowel cancers, for example. And it is a chemotherapy agent that causes neuropathy. So there is a condition called chemotherapy-induced peripheral neuropathy. And often people who are receiving oxaliplatin-based chemotherapy experience things like pins and needles in their fingertips in response to touching something cold, for example. So that's why it's called peripheral neuropathy. But in fact, during the course of my research with those 73 people with dysphagia, I found that people who were receiving oxaliplatin chemotherapy were reporting quite unusual swallow difficulties, different to the rest of the cohort. So what they often reported were things like a sensation of their throat closing off or a spasm in their throat when they tried to swallow, and a painful pins and needles sensation in their throat as well. And actually, they reported that sometimes in response, yes, to cold or chilled boluses, but also sometimes in response to hot boluses as well. And one participant reported it in relation to carbonated fluids. It was a new finding. The literature on chemotherapy-induced neuropathy is relatively limited. There are tools for screening for it, which don't really consider dysphagia as a side effect. It struck me as interesting, not only because of the very different, representation of dysphagia. We wouldn't often see those signs in other dysphagic cohorts, but also because as speech and language therapists, when someone does have a dysphagia, sometimes we recommend some of those things as compensation, right, for their dysphagia. We would try and promote swallow function by recommending that they take something hot or chilled or carbonated to try and initiate the swallow in a bit more of a prompt, timely fashion. So this actually goes against what we would normally recommend for some cohorts. So we need to be careful in people who are taking oxaliplatin-based chemotherapy treatments.
I think in our episode with Harmeet Bedi, the pulmonologist from San Francisco, we were talking about aspiration and aspiration-related pneumonia, and he told us that he is seeing an increasing number of people who are taking modern immunotherapy drugs for cancer, and that they are also having an increasing number of pneumonias as an adverse event, and that this could also affect dysphagia from problems with swallowing and breathing or respiratory coordination. Have you seen any of this as well?
I suppose this cohort study that I carried out was designed to take a large group of people who had cancer and see whether they had dysphagia, regardless of the type of cancer, and therefore also regardless of the type of cancer treatment that they were getting. I can't remember the number of people receiving targeted therapies, but it was certainly not as high as the other forms of cancer treatment. It probably is the case that I just didn't have enough people in the study to carry out a very detailed examination of swallow function in those receiving targeted therapies or immunotherapy. But it certainly was the case that those who were getting the targeted therapy treatments were not any more likely to have dysphagia than anyone else.
Okay, thanks. And what would you recommend a clinician, a colleague who is going to see a patient from this population tomorrow for the first time? What should he or she consider in the diagnostic process?
I think the most important thing is just ask the person whether they're having any difficulty eating, drinking, or swallowing, because in the research that I carried out, I also discovered that of those 73 people who had dysphagia, a very small fraction of those had documented dysphagia within their medical notes. We have to remember that people who have cancer have that huge variety of different symptoms as part of the disease and as part of the side effects of treatment for that disease as well. And that dysphagia is something that people have probably never heard of and something that they cannot discriminate between when they think about those other things I mentioned, like lack of appetite. They are probably thinking in terms of, well, I just can't get food and drink down, not whether it's a physical cause of not being able to get it down versus something else like an appetite loss. So just ask the question. And, the research was published in the Journal of Pain and Symptom Management, and that was a deliberate choice because I hoped to reach an audience of doctors and nurses more than simply reaching an audience of swallow experts, because patients are not being asked in the first place whether they have any difficulty swallowing. So my first piece of advice is ask the patient whether they have a difficulty with eating, drinking, or swallowing, and then follow up with someone like a speech and language therapist or a dietitian. I think the other important point as well is that when they do get follow-up, again, this is unpublished data, but what I found was that the types of foods and drinks that people were avoiding were often high protein, high carbohydrate foods in particular. So I mentioned it was foods that people mostly had a problem with. And we also know that dietitians tend to recommend that patients take a high protein, high calorie diet when they have cancer. And that is both because it predicts a better outcome from their cancer treatment, but also improves survival rates, as far as I understand, in cancer as well. So when they do get evaluated, even if you are maybe a speech and language therapist who wouldn't ordinarily be concerned with dietary intake in terms of nutritional support, do think about that. And of course, dietitians should be involved as early as possible.
Yeah, thank you. And then if this person is done with the diagnostic process, is going to think about the treatment that could or should follow afterwards, are there any things that he or she should consider that are different from the treatment of dysphagia in people with other conditions?
Yeah, I suppose to some extent that's difficult for me to answer because the research I carried out was very much diagnostically based, but I certainly did find that compensatory strategies were very, very helpful for this group of people. The question of whether any swallow rehabilitation exercises or swallow skills training or anything like that may be helpful in this group, I'm not too sure. I think we need to understand more, first of all, about motor function in this group of people and how it's impaired. We know, for example, that grip strength, for example, is reduced. So we know that there is a lack of muscle activity in this group of people who have cancer. We just don't know to what extent it affects swallow function. So I think if we start to measure swallow pressures, if we start to profile activation of swallow and identify whether there is a delayed initiation of the pharyngeal swallow or prolonged oral phase and all of those things, we might start to understand better whether we need to or can provide sensory motor rehabilitation or support for people with this particular kind of dysphagia.
What I found really interesting, what you were saying earlier, that you decided not to use instrumental assessment in your study, just because, which made totally sense. People are, for example, in palliative care, and you would rather do a clinical swallow evaluation than putting them under this longer procedure of doing a video fluoroscopy, for example. And then it's always the question, what are we taking from this assessment as a consequence? Does it have any consequence on the treatment? But then thinking about compensatory strategies, oftentimes it's said that those should be assessed with instrumental assessment. For example, a chin tuck can both be helpful, but in another patient it could do harm, making the swallow more difficult. From your clinical experience, maybe, how do you decide whether to do an instrumental assessment, especially in regard to the treatment?
That's a good question. I think if I reflect on that, the decision to use an instrumental swallow evaluation like video fluoroscopy or FEES is usually driven by whether I suspect that that person may have risk of choking or aspiration. I think that may be a difference in healthcare systems worldwide as well. It's not common in Ireland to immediately conduct an evaluation like that. We typically start with a clinical bedside swallow evaluation. But then reflecting on what you're saying, perhaps my decision not to use those evaluations is also being driven by a lack of knowledge as to what the cause of dysphagia is in this group of people as well. So perhaps if we knew more about the sensory motor causes of dysphagia, that might warrant further instrumental evaluation to identify targets for improvement, right? The decision not to use instrumental evaluation is probably being driven in my mind from my patients that I see by a lack of clinical sequelae from their swallow dysfunction, and because I have the impression at bedside that they are managing well. If there's an improvement in quality of life, if there's an improvement in oral intake, then that is a positive outcome measure. And unless there is a need for an evaluation to determine whether they are aspirating, I haven't been using those two techniques. The other thing, of course, to mention is that that doesn't mean that other instrumental techniques could not be used to profile them in more detail, like tongue pressure measurements, for example, which are also not invasive. I did consider that as part of this research. In fact, I was using a new device, which unfortunately never came to market, but that device just had some limitations rather than the IOP device, which we're probably all familiar with, which uses an air-filled bulb to measure swallow pressures. This device had a sensor that was placed directly inside the mouth, but it had difficulty sticking to the mouths of the people with cancer. And I suspect that again could be because of the lack of saliva in their mouths. There are other forms of instrumental evaluation. Ultrasound as well would be another good choice, particularly with its ability to profile tongue movements. So the future is bright probably for further research in this area.
Thank you, Ciarán. That was a really interesting topic that, as you said, definitely needs more attention in research and clinical practice. Do you have any last words of wisdom for our listeners?
I think probably, as I mentioned before, in this group of people at least, ask if they're having swallowing problems. Education is important. When we're addressing dysphagia, we need to ensure that we address nutritional support as well at the same time. But I think the biggest thing for me is probably that we need to recognize that while swallowing difficulties are often profound, enduring, and significant in people with head and neck and esophageal cancers, that doesn't mean we should be neglecting this other cohort as well. And indeed, other cohorts of people with cancer, maybe non-solid cancers, who are also under-researched. And that we should turn our attention to those people to offer them the best possibility to live their lives to the best possible extent while they are living with this unfortunate disease. One other positive outcome that happened as a result of this research as well is that I was invited to collaborate with some colleagues from clinical nutrition and dietetics from another university in Ireland, University College Cork. The lead author on this piece of work is Professor Aoife Ryan. She and I and other colleagues as well, including a dysphagia chef and a photographer, worked together to develop some recipe books designed for people with swallowing difficulties who have cancer. And the recipe books are produced in order of IDSI level. There's a 6, 5, 4, and 3 IDSI level recipe book for people who have dysphagia and who have a cancer diagnosis. And they were developed in order to try and help people with cancer to eat as well as possible despite their disease. The booklets are designed not for clients to download directly, for example, from the internet, but rather for clinicians to hand out to their patients. And that is only because we were keen as co-authors on the series that any person who has dysphagia or nutritional difficulties should be linked in with a speech and language therapist or a dietitian or the appropriate healthcare professional. But these booklets have been a hit, a big hit. Patients really like them. Clinicians really like them. They provide meal ideas for people who are often uninspired by food. And if any listeners of this podcast are interested in hearing more about that, they're very welcome to contact me. And I think that my contact details will be in the show notes for this episode.
Yes, absolutely. Thank you so much, Ciarán, for taking the time and for sharing your valuable knowledge with us today. Thanks so much. Take care.
You're very welcome. Thank you.
Thanks so much for listening. We hope you enjoyed this episode. As always, if you would like to get in touch with us and stay informed about upcoming episodes, you can follow us on Instagram at Dysphagia Matters, on Twitter at DysphagiaPcast, or visit our website at dysphagiamatters.org. Take care, everyone.